to that core topic, let's answer the first most core question. What is shock? Shock is a life-threatening condition of circulating failure causing inadequate oxygen delivery to meet cellular metabolic needs and oxygen consumption requirements. And that leads to it produce cellular and tissue hypoxia, which ends up in sign and symptoms of hypoperfusion like oliguria, altered mentation, cold peripheries, and manifest in biochemistry like lactic acidosis, wide anion gap, etc. Now here, the consequence of shock is diagnosed by biochemistry and clinical science, and where a point of care ultrasound cannot help. So we can diagnose heart failure with point of care ultrasound, but cannot diagnose that this is cardiogenic shock. So we should not fall under the impression that with an ultrasound probe, everything can be solved. So starting with the first point, that ultrasound cannot be used for diagnosing shock. However, when we understand the shock, I would take a couple of slides to go back to the basics of hemodynamics, that what do we look into those perspectives while diagnosing the type of shock as well as differentiating the type of shock. We know that it is all about the oxygen delivery. In oxygen delivery, the core is at cardiac output and content of oxygen, which is dependent on stroke volume and heart rate. And ultimately, stroke volume is dependent on preload, contractility, and afterload. And oxygen content is dependent on saturation and hemoglobin. So especially in stroke volume and cardiac output determination, ultrasound can be of great help. And I would say that at bedside, nothing else but ultrasound can help in detecting the alteration or pathology in these aspects. So let's go back to the old table, which help us in differentiating the type of shock. We know that we know four classical types of shock from the old classical textbook descriptions, whether these things written typed in black, which can be diagnosed by either central venous catheter or pulmonary artery catheter in convalescent settings. But in today's ultrasound guided intensive care, ultrasound enabled intensive care, and ultrasound learned intensivist would go back to those red things which are typed below it. So look at hypovolemic shock. Previously, we used to look at CVP and PCWP when it is low, but now we look at the IVC variability and LVOT VTI variability to look at the patient's hypovolemic status. Plus, the same ultrasound is going to help you in where that fluid has gone, if it is there in pleura or peritoneal collections, etc. Same in distributive shock. The variability is high, but it can help us in finding out the cause of shock, sepsis or focus of sepsis by diagnosing pneumonia and peritoneal collection by ultrasound. In cardiogenic, without saying, this is the extremely helpful modality, not only to help us to diagnose low ejection fraction or poor pump, but the region wall motion abnormality and valve pathology can lead us to the actual cause of the cardiogenic shock as well. In obstructive shock, this is one part of type of shock where clinical examination and many of the biochemical or ECG examination can also be having great limitations, but point of care ultrasound can be the diagnostic, like diagnosing RARV dilatation in in pulmonary embolism, diagnosing pneumothorax or cardiac tamponade. This is practically impossible without having point of ultrasound. And cardiac output monitoring. With say we can with any type of shock, the core is cardiac output. And if we learn the capacity of monitoring cardiac output by ultrasound, then it can not only help us in diagnosing the different types of shock as it is stated here. In hypovolemic and in hypovolemic shock, cardiac output would be low. In accept and distributive shock, it may be high or normal. But again, in cardiogenic and obstructive shock, it will be low. Again, differentiating between right and left heart failure, you can definitely have an immense help from the point of care ultrasound, where previously known indices, we rarely use PA pulmonary artery catheter nowadays for the obvious reasons. but we definitely use this echo-based or ultrasound-based indices, where starting from inferior vena cava, whether it is full or empty, it can be full in both right and left heart failure. But the right ventricular contractility indices like TAPSE and tricuspid valve S prime will be immensely depressed in right heart failure. It may be normal in left heart failure. But left heart failures indices like left ventricular ejection fraction, MAPC, and mitral valve S prime will be severely depressed along with the regional wall motion abnormalities in the left heart failure, which will be normal in right heart failure. In both biventricular failure, both will be depressed. Again, the regurgitation, the secondary MR or secondary TR will be obvious once the chamber dilatation goes beyond the limit. Even right-sided pressure with pulmonary hypertension, judged by PASP, and left heart failure can be differentiated by high E by E prime and left atrial volume index by in heart failure. So here, why I am putting this indices in a tabular format, that once this is the basic knowledge with which we will approach a patient. And when we try to differentiate the type of shock, we need to have a methodological view where most of the people jump onto the conclusion by just by ending doing echo and then will not complete the whole. And that's why a complete protocol needs to be learned where we control our again, I'll going back to the same topic that heart failure can be diagnosed, but cardiogenic shock cannot. And that's why we have to keep this limitation of point of care ultrasound in mind. So with these limitations, we'll go back to our core topic, that how would ultrasound be used in managing shock? Of course, we will start with the differential diagnosis of shock. Then we'll see how it can be used during monitoring as well as in treatment. So starting with, say, we often as an intensivist with this group of intensivists who are already uh, work, they are postgraduate doctors who have known and understood the different type of hypo. I don't need to give the examples of hypovolemic shock and distributive and cardiogenic and obstructive shocks. But one thing I would like to emphasize here is rarely patient present with a single etiology. Patient with congestive heart failure comes with sepsis. Patient with pulmonary embolism comes with dehydration. Patient with diarrhea also with presents with decompensated heart failure. So this type of permutation and combination is the real life scenario. So the textbook picture of classical heart failure or classical septic shock or only pulmonary embolism is actually rare. And that's the reason why when a student comes out of this college and then start putting ultrasound probe and start putting differentials, we always tend to believe that, okay, there will be only one cause for one patient. And that's where I would remember myself that there is an Occam razor, which is Hicking dictum. That means Occam razor says that there should be one cause to explain all the sign and symptom of the patient. But the Occam's dictum says that you can have multiple etiologies to explain multiple sign and symptoms in the same patient, and which is, I think, is more likely to be true. In frequently, today, after end of this session, we will discuss couple of cases depending upon the time permits, where I will give you the case scenario and you all will try to speak out what are your impressions, and then taking point about the management of the same. So giving few examples of the multiple etiologies, which I have already enumerated few, is either patient with myocardial infarction and diaphoresis and diuresis leads to hypovolemia along with cardiogenic shock. Infected malignant ulcer with DVT can cause shock, where we have infection as well as obstructive shock. Severe pneumonia presenting with hypoxia and MI will have septic and cardiogenic shock together. Severe diarrhea with AKI. So that means when you put an ultrasound probe, you should not jump onto the ultrasound probe without having following the fundamental basic of taking history, clinical examination, put your differentials, and then put the probe on the patient to find out the differentials. But what do you want to find out? We will discuss two particular protocols. There are many, but two protocols. But amongst, by putting those, before we go to the flowcharts of those protocols, what we would like to see. When you interrogate left ventricle, we start with usually size, whether it is filled or empty. Then look at the contractility, whether it is globally depressed or patient has regional function abnormality as well. Then have an idea about the E by A ratio or and filling pressures, whether it is restrictive filling, and even looking at the LA diameter to look at whether patient has diastolic dysfunction and whether it has restrictive filling or normal filling pattern. This is going to not only help us in understanding the patient's current status on Frank-Starling curve, whether they can take fluid, not only take fluid, can they tolerate fluid? So patient with already having restrictive feeling pattern and severe diastolic dysfunction, they would tolerate fluid when it is given slowly and will not tolerate fluid if it is given fast. So this answer can be judged or anticipated by studying the diastolic function in a given patient in a given hemodynamic scenario. And with changing hemodynamic scenario, this diastolic function is also bound to change because the adrenergic drive settles down the moment you resuscitate this patient. So this means, what do I mean by that? That with changing hemodynamics, the adrenergic state will change, and so is the systolic and diastolic function of LV can change without changing the external dose of vasopressors. And that is very important. And that's why the core component of ultrasound is serial assessment. Keep on assessing again before you make a major turn in your decision making, right from okay, now I have given enough fluid, I want to start vasoactive medications, again put the probe. When you want to de-escalate, again put the probe, and that's what it is. Right in right ventricle, the LV size versus RV size ratio, contractility is judged by tricuspid annular peak systolic accentuation. We are going to discuss about that later. Pericardial fluid present or absent. Is there evidence of tamponade? Significant valvular pathology is there or not? Pulmonary hypertension is there or not? Intracardiac mass or vegetation is found or not? IVC diameter and collapsibility. We will spend some time on it. Hepatic vein, portal vein, and renal vein Doppler. When it is put together, we will discuss about the access score and its utility in assessing the congestion in the system when you are at the peak of resuscitation. Lung ultrasound is not only going to help us in find out effusions and pneumothorax and pneumonia, but also help us in find out whether your fluid has crept into pulmonary interstitial spaces. And that B line index can help us in anticipating or judging what must be the extra vascular lung water. So more the B lines, less likely more fluid can be given, and vice versa. And again, depending upon the congestive assessments, your fluid management strategy or de-escalation strategy needs to be titrated. And as far as assessmenting abdomen, ascites, and abdominal aorta, presence or absence of ascites, abdominal aortic aneurysm, dissections can be judged as a differential for shock. And last but not the least, the peripheral veins are assessed to find out presence or absence of DVT. Now, with this all summary, this is what we are going to use to put this into practice. So there are multiple protocols. I would discuss two protocols here. One is this fast crash protocol developed by WinFocus Group, where the starting point, say we all know what to look for, we all know what to interpret. Even after that, most of us tend to jump onto the conclusion by finding one or two points, and that can lead to it leads to serious error. And that's why I would strongly recommend that follow up. All protocols by and large, they tell the same thing, but we need to what you follow the protocol whatever you are comfortable. We use either fast crash protocol or rush protocol. Let's discuss fast crash protocol first. It starts with inferior vena cava ultrasound. It will first assess the IVC diameter and collapsibility. If the IVC diameter is collapsing in any patient with shock, if IVC diameter is collapsing, more than 30% and a diameter is less than 1 centimeter, that means this patient has hypovolemic or distributive shock. Now, by doing echo, you find out whether LV is hyperdynamic, RV is hyperdynamic, and by doing lung and abdominal ultrasound, find out is there any free fluid in pleura or peritoneum, and then try to put differentials. If patient's IVC is full, more than 2.5 centimeter and non-collapsing, then by and large this patient has its hypovolemic or distributive shock is ruled out, and you should start looking for the causes like cardiogenic and obstructive shock, where if there is presence of pericardial fluid and tamponade, or patient has tension pneumothorax or pulmonary embolism, depending upon that you will find either RARV dilated in pulmonary embolism, region of motion abnormality, global hypokinesia, regional hypokinesia, and acute myocardial infarction, global hypokinase, dilated cardiomyopathy, academic. So that can be helped. So step one, IVC, step two, echo, then look at lung ultrasound, and last but not the least, you go to venous ultrasound. So second step is echocardiogram, as it is shown in the previous slide. And from echo, so first is IVC, second is echo. Then echo, you find out whether cavities are normal or reduced, or cavities is dilated. That means cardiac chambers are dilated. And depending upon which chamber is dilated, you start putting differential to it, and then go to lung and abdominal ultrasound. Then last is look at the aorta, look at the vein to find out DVT. The yellow boxes are differential diagnosis list, and the red boxes here helps us to find out the therapeutic aspects of this. So you put ICD by first put marking the skin by ultrasound. So point of care ultrasound or the focus is not only helping you to differential diagnose, but also help you to treat the cause. You may put ICD, you may put pleural tapping, you may do ultrasound guided ascitic tapping, arterial line insertion, venous lines insertion, insertion of ECMO, cannulae, IABP insertion, even PTCA cannulae, arterial cannulations are done under focus guidance. So focus is not only helping you in differential diagnosis, and this is the fast crash protocol. Now let's have a look at another similar protocol. Use whatever protocol you like, but stick to one protocol and complete all the steps of each the protocol you follow. In Rush protocol by Philip Pereira, published way back in 2010, they have three components: pump, tank, and pipes. Differentially, the system here you are going to pump, assess the heart, where put the proposition in parasternal views, long and short axis, as you can see it here on point A. Proposition B, subxiphoid view. Proposition C is apical view. This type of methodological approach helps you not to miss any point. Again, look at the pericardial effusion, left ventricular contractility, right ventricular strain or size, LV-LV ratio. So that's what you look for pump. So in pump, what you look for? Pericardium, LV, and RV. And second point is tank. Tank is it reflects the indirectly judgment of the circulating volume. The probe position A is IVC views. Probe position B is fast or right upper quadrant and pleural view. Probe position C is on the left upper quadrant view of fast and pleural view. Probe position D is fast uh, uh, pelvis component, and probe position E is lung views. Lung views, you especially look for pulmonary edema, lung rockets. For IVC views, you look at the IVC size and collapsibility. You can even use jugular veins, whether it is small or large, femoral vein, small or large, to have a that, but their reliability is much lesser than inferior vena cava. You can use eFast, and that's what the 4 points are all about. And the third is pipes. Pipes are nothing but the in aorta, You can judge from suprasternal view, parasternal view, epigastric aorta, subalumbilical aorta. This multiple views to examine the aorta is nothing but to detect uh, aneurysmal dilatation, dissection, or rupture of aorta, which is one of the very common cause of hypovolemic or hemorrhagic shock in the West. In India, it is less diagnosed either because till now the ultrasound use was less, but as the ultrasound use is increasing, this cause is increasingly diagnosed. You can detect femoral or popliteal DVT from position E and F. So what is important here is this pump, tank, and pipe. The point of where do you put ultrasound probe to look for what, and complete this total, you have almost 16 points when you to put the ultrasound probe and ask yourself a very meticulous question what you want to look for and whether your finding is yes or no. And you may put this into perspective by this mnemonic called HIMAP. This HIMAP is nothing but summary of what you look for in pump, tank, and tubes. H, HIMAP stands for heart, where you examine the heart and summarize it. IVC, size and collapsibility or distensibility. M is Mauritian's pouch, whether below diaphragm is there any free fluid. A is aorta and deep veins, where you need to look for aneurysm, dissection, rupture, DVT in veins. And last is P, whether there is a pleural effusion, pneumothorax, A profile, B profile, B dash profile, B line index, etc. So this is a more systematic method where you can just create a HIMAP as a summary of your findings for differential diagnosis of cause of shock. Multiple such protocols are published right from 2009 to currently. You can have multiple short forms designed by multiples. The falls, fear, focus, this rush. So we have discussed this fast fresh protocol and rush protocol and this HIMAP mnemonic from it. As this table summarizes various components used, but by and large, we recommend use a protocol which covers practically all the component. That's where you can see here from 1 to 8, this rush pump tank pipe protocol, and that's the reason why this rush protocol is more popular and more methodical, and that's what most of people use it. And I don't need to repeat it that in pump, tank, and pipes, in which type of findings you will expect. We have already, you must have already studied the causes of shock. And in interest of time, I would go to say when you start looking at heart or the pump, what you want to look at is if your left ventricle, total heart, if you want to accommodate on your ultrasound screen, if it is more than 15 centimeter depth is required, then by and large, you start thinking that this heart is big. And if it is smaller and you look at that whether LV wall is scathing, as you can see in this video, look at the first left video of both upper screen. You can see that during contraction, the LV walls are touching nearly each other during systole. And you look at the bottom screen, it is very obvious that this LV's contractility is poor and LV is enlarged. So this is what we start from, eyeballing, that how does this LV look like? Full, contracting full or empty, contracting well or not contracting well. And then if it is not contracting well, then the next question comes is whether it is regional, single left ventricular, right ventricular, global, all. And if it is only left ventricular, then the question comes whether it is. So this is again the example of kissing wall. As you can see during systole, practically no LV cavity is seen. Here the diagnosis is very obvious that this patient has hypovolemia and can safely take some fluid. Here you can see that the other way around. Left ventricle is hardly contracting and it doesn't require a very you don't require a lot of experience to say that this LV, even if I can give fluid, it has to be very careful. This LV doesn't have a And this is only left ventricle failure. Here you can see that this is all four chamber dilated, and this is the patient. You will be extremely careful of even giving a trial feed without concluding. But we will take some example at the end to see that even this type of patient, you might have to try with an aliquots of fluid to fool them optimally. But you will be extremely careful. So by looking at this scenario, you should be able to see. Again, look at this from the left. This is normally contracting LV. The upper right, you can see that anterior wall is not contracting. Lower left, anteroseptal wall is very weak. And the lower right, the posterior wall is very weak and not contracting. So that means from eyeballing, whether it is full or empty, then you, if it is contracting well or not well, if it is not well, then whether only left ventricle or right ventricle or both. If it is only left ventricle, then you can think about whether this is a regional wall motion abnormality or a global hypokinesia, and then interpret accordingly. So then you start moving towards cardiogenic shock. Here again, when you interpret, the next step will be your tank. Whether you look at the IVC on the left side, you can see that IVC is either contracting or not, collapsing or not collapsing. And on the right side, you can see that this is a compression ultrasound of the femoral vessels. We can see the femoral veins are completely compressible, and that practically rules out presence of DVT in that particular segment of vein. So this is where the HIMAP summary would be. And this is, I would consider that we would be following this pattern in the examples at the end. And I would keep this type of blank forms when I start assessing for shock so that I don't miss anything and complete the protocol before I include anything in the case and before starting deciding. As far as management is concerned, it helps us in determining whether this particular patient is fluid responsive. That means in treatment at the start, with a dilated heart, we should not conclude that this patient is not fluid responsive. And with the empty, you should obviously start with fluid responsiveness, but do not end up your examination there. So both sentences are equally true. These are the, we will discuss in detail about IVC collapsibility, passive leg raising test, and how we interpret cardiac output variability and LVOT by LVOT VTI. I need to discuss about the role of ultrasound in putting central line and arterial line and ascitic and pericardial tapping. That is out of scope for the discussion today. But this is especially important role of ultrasound in treating shock and its causes. As far as monitoring is concerned, while you resuscitate the patient, IVC size and collapsibility will keep on changing. Right ventricle, left ventricular function will also keep on changing depending upon the dose of inotrope and vasoconstrictors. LVOT VTI, by which you will judge the cardiac output and stroke output, will also keep on changing as the etiopathology is treated and patient is resuscitated and cause is treated. And that's why serial monitoring is the key. Many patients having deep vein clot, the clot may get dislodged and you need to interpret accordingly. And that's the reason why you need to keep on looking at periodically. Pericardial fluid can get recollected after tapping, or patient may have regional tamponade, and especially in patient having cardiothoracic surgery. So it need not to be that patient have fluid all around. You might have to pay attention to those variants as well. Though they are rare, but is not rare unless you look, if you keep looking for it. Free fluid in abdomen, we have discussed. Distal perfusion in IABP patient with IABP or ECMO cannulation is also essential. After intubation, right and left side lung sliding to optimize the attitude position is also part and parcel of managing the shock. Urinary bladder with a blocked urethral catheter. If you are looking for this patient is oliguric, but ultrasound probe can within a second differentiate whether this is low urine output is because of low production or blocked catheter. So this is just a list This you can have more longer list of use of ultrasound in managing shock. But now coming back to fluid responsiveness, we know that the preload is volume and not the pressure, and preload responsiveness can keep on changing depending upon the contractility state of left ventricle. And this state can be judged by either static indices, which are not recommended because of multiple limitations. We focus more on the dynamic indices of fluid responsiveness, which is especially IVC collapsibility or distensibility. We can use superior vena cava collapsibility, and this, let's take one by one. So important thing is very common is inferior vena cava size. Especially at the both extremes. If it is less than 1.5 or 1 centimeter and total collapse, you can safely give fluid. At the other extreme, no change without collapsibility more than 2.5 centimeter. The CVP is estimated to be more than 20 centimeter, and be extremely careful or less likely to benefit from. But in between 1.5 to 2.5 centimeter, we need to pay attention to the collapsibility in a spontaneously breathing patient or distensibility in intubated and mechanically ventilated patient. But if it is more than 50% collapsing, then it is more likely that this patient has some room in the circuit. But with certain word of caution, I would utter from this slide where to measure IVC. IVC diameter needs to be measured at perpendicular in subcostal longitudinal view, where IVC enters right atrium, and it's from the vena cava to right atrial junction. We should have at least 1 to 2 centimeter distally, and certainly do not measure where this C line is. This will overlap where the hepatic vein is entering into IVC, which can falsely measure, over measure, or the IVC diameter can be falsely overestimated. And this tubular artifact needs to be considered because IVC is an oblique oval. Where you measure matters the most. If you measure from wide to the largest diameter and then try to keep the probe stable so that during inspiration you don't move from this blue line to red line. Otherwise, even without IVC collapsibility, it may appear on M mode that this IVC is collapsible, but in the fact it may not be. And that's why what we do is first measure it, look at into cross-sectional view, identify whether IVC lumen is collapsing or not collapsing. Then from there, you turn right angle, then open up and measure the IVC in this longitudinal view, so that you don't miss and misinterpret. Again, differentiating IVC from aorta, I need not to emphasize more. Now, IVC distensibility index and collapsibility index. In distensibility index is used for patients mechanically ventilated. During inspiration, IVC distends because of reduced venous return, and vice versa during inspiration. So maximum diameter minus minimum diameter divided by minimum diameter into 100, and the cutoff value taken here is 18%. While in spontaneously breathing patient, maximum minus minimum divided by minimum here is collapsibility in spontaneously breathing patient, where more than 30 to 40%. Say when you took at lesser value, the reliability goes down. Superior vena cava collapsibility. Superior vena cava is very difficult to see by transthoracic ultrasound, but when it is measured by transesophageal ultrasound, the cutoff value of IVC superior vena cava collapsibility is 36%. As you can see here in this picture, when you measure it, the IVC is very small and nearly totally collapsing. As compared to here, the IVC is reasonably large, but it is still more than 50% collapsing. Again, when you measure it at an oblique level, be careful of suboptimal images. If you obtain and start measuring, you can see that here 1.97 centimeter is IVC diameter. But look at the angle of measurement. This is absolutely wrong. This is overestimation because of wrongly put angle. If you cannot correct the angle, you can use anatomical M mode to measure at right angle. The correct actual diameter is 1.6 centimeter. So from previous value, you don't think about giving fluid. From this actual value, now you can say that, oh, I can still try some fluid. And that's where the limitations of ultrasound that man behind machine matters the most. Here, again, in the same, you can see on the left side, clearly collapsing. On the right side, this IVC is not collapsing. So don't get engrossed by only looking at the IVC. Look at around. Here, again, you can see that on the left side, even though IVC is collapsing, patient has a lot of pericardial fluid. But this patient, despite having pericardial fluid, IVC is collapsing. On the right side, you can see that patient has pericardial fluid and IVC is not collapsing. Right. So this is how the difference is. So if you jump the conclusion just from the IVC, you may end up in making a big blunder. And that's why from one point, don't jump onto conclusion. And that's where the importance of protocol is. If you look at IVC as an oblique oval, from subxiphoid approach, if you look at the transverse plane, you can see that diameter is different as compared to transhepatic approach. And a study done from Mumbai, they said that around 4 millimeter diameter difference can be there between subxiphoid and transhepatic approach, but the collapsibility remains the same. So depend both, don't compare because difference can be as high as 4 millimeter in measurements. This we have already discussed, so I would not repeat here. As far as now fluid resuscitation protocol based on IVC indices. So Lee have developed protocol where they have divided all patients into underfilled, normal, or overfilled. In underfilled patient with IVC less than 2 centimeter, straight away you go to fluid resuscitation. With IVC more than 2.5 centimeter, this patient require fluid restriction and start thinking of inotropes or vasoconstrictors straight away. In between, you think about patient is intubated or not intubated. If patient is intubated, you do passive leg raising, look at the IVC collapsibility. In intubated patient, you look at the patient is passive, that means totally paralyzed, in which the distensibility index can be seen. If it is more than 12 to 18%, you can see that this patient can also take up some fluid. If patient is triggering, should be interpreted just like non-intubated or spontaneously breathing patient, where you interpret the lung ultrasound. If there is A lines and profile or lung rockets, you can start some very small quantity fluid challenge and see the improvement in hemodynamics. If it doesn't help and saying B lines or already having B lines predominance, then you go to right side, which is fluid restriction. So this type of Lee protocol has helped us. It found a very protocolized manner in which you can restrict fluid or give fluid based on ultra findings. Now, when manage patient with septic shock or any shock, initial period is you must have heard this ROSD or SOSD. There are 4 stages of fluid management in shock, where we all keep on focusing on the resuscitation phase and focus on de-escalation phase, where patient is congested, and this congestion has lot of it has direct correlation with the adverse outcome from in intensive care. So de-escalation or de-resuscitation or timely diuresis is the key. And to find out that Waxer score or the congestive elements of the system needs to be looked into from time to time when your initial resuscitation phase is over. Sometimes patients are already congested in cardiogenic shock and they already have this congestive phenomena. So to grade their amount of congestion, this type of objective grading is helpful. It starts with IVC diameter. Waxer score considers 4 things. One is IVC diameter. Second is hepatic vein flow. In the same image as longitudinal view of to look at the IVC, you can see the hepatic vein entering. You put the pulse wave Doppler there, and you can get this image generated. So you interpret as atrial, systolic, right ventricular systolic and diastolic waveforms. So if the systolic waveform is bigger than diastolic is normal. The reversal of pattern, the systolic is lesser than diastolic is mild abnormal, and systolic upwards and in the systolic reversal of the flow considers that it is severely congested system. In portal vein, the pulsatility is less than 30%. If it is increased beyond 30% up to 50%, it is considered mildly abnormal. And if it is more than 50% pulsatility, considered severely abnormal. In intrarenal vessels, you need to look at the venous flow. Venous flow is usually continuous. And if it is systolic and diastolic with no flow in between, is considered mildly abnormal, and total disappearance of systolic flow and only diastolic flow is continued, which is a severely abnormal system. So based on the two most abnormal features along with the IVC diameter, you grade whether it is VAXS grading 0, 1, 2, or 3. And this has correlation. And this is how you can give either VAXS score 1, 0, 1, 2, 3, or even A, B, C according to this table. Now, important thing here, word of caution is the filter. You need to have at least 20 to 40 centimeter filter. Say for cardiac assessment, for the regurgitation flow, you use 60 to 70 centimeter per second filter. You need reduce it to 20 to 40 centimeter. Because you are here trying to judge lesser flow rates. So your the filter setting for the pulse wave Doppler or the scale should be reduced so that you can detect this type of lesser velocity flows. And that's why 20 to 40 centimeter recommended for hepatic vein, 16 centimeter or around 20 centimeter, 15 centimeter for portal vein. And for renal vein Doppler, you may increase to 50 to 100. I think there is an error. This is again say 15 to 20 centimeter for renal vein Doppler. Systolic to diastolic flow reversal in hepatic vein is associated with odds ratio of up to 4 times increasing likelihood of acute kidney injury. So it is not only the hypoxia or the hypotension, it is the backward pressure, congestion from the system also increases the likelihood of kidney injury. And so is the case for portal vein. This values have been proven in various studies that when your adverse kidney outcome can be as high as 2.2 times if your portal vein pulsatility index is more than 30%. The same is the case for kidney congestion as well. Now, question about LV assessment. You can have, in interest of time, I would not read out this various indices where after having perfection in their initial ultrasound handling, you can measure mitral valve S prime, MAPC, regional wall motion. You can look at the segmental analysis and the details of diastolic dysfunction. I have already told you about that patient with diastolic dysfunction will not tolerate fluid as much as those without it. Right ventricle is a frequently neglected ventricle, and that's the reason why we need to also have a look at the TAPSE, which is one of the easiest to measure. Right ventricular hypertrophy, which is frequently missed with a patient with RARV dilatation. Don't miss to measure in a subcostal view. This is where the right ventricle free wall can be measured and should be measured. If it is more than 5 millimeter, you should think that this pulmonary hypertension is chronic, and that's why you should start putting differentials accordingly. LV to RV ratio is helpful if it is around RV is around 0.6 to 1 is LV. If it is beyond 0.6 up to 1 is mildly dilated, up to 1.5 is moderately dilated, more than 1.5 times the LV is severely dilated. And that's how you will judge that how the right ventricle is dilated. And here diastolic dysfunction can be studied. And last is cardiac output monitoring, where your LVOT diameter needs to be measured, and from that the uh, the LVOT area is calculated by this formula, which is pi r square, and pi is diameter divided by 2 is the radius, and when you transfer this 3.12 here is equal to diameter square into 0.785. This is how you find out the LVOT diameter, and then you measure LVOT VTI by putting your cursor into four chamber view, sorry, apical five chamber view, and the cursor location is very important. The normal value of LVOT VTI is 20 plus or minus 2 centimeter. And here, as it is shown, where people tend to generate whatever envelope you get, but important thing here is there is no clicks visible in this LVOT measurements. So this is says that the your sampling volume is very much into left ventricle, and that's how it can lead to LVOT flow. So before you jump onto, so you need to have a perfect of how do you generate the image, where do you put the cursor. You need to have LVOT envelope seen this smooth, followed by the after click. The after the envelope is must. If it's there, then that means your sampling volume is properly in LVOT, and then you should measure it. So if you see two clicks, that means you are very near to the aortic valve. If you see no click, that means you are very much into the left ventricular cavity. And that's why the first one is LVOT VTI envelope followed by one click. This is the way you should monitor, get the image, and every time you measure it, you need to get this image. And you can see that here, two things you need to look at in LVOT VTI, the peak systolic velocity or the peak flow velocity, tip to tip. You can see that during inspiration, the flow reduces, during expiration, it increases. So this variability, if it is more than 12%, the peak systolic variation, peak systolic velocity variation more than 12% is suggestive that this patient is volume responsive. Or you can actually measure the LVOT VTI envelope. And if that LVOT VTI variability more than 10% in respiration is also associated with flow variability. If patient, you can actually measure the aortic flow in transesophageal echo, and more than 19% threshold variability during inspiration is also associated with fluid responsive. The passive leg raising test, you do this way. You monitor the LVOT VTI continuously. First with propped up position 45 degrees, and then after making the patient flat and leg elevation. So after changing position, measure after 1 minute, exactly at the same spot, exactly get the proper view, and then measure the improvement in LVOT or the stroke volume. If it is more than 12% rise in stroke volume with flat leg head down position, that means this patient is fluid responsive. Importance of this passive leg raising is it gives a practically a reversible fluid challenge of roughly around 30 ml, 300 ml. And when you propped up this patient, the fluid is shunted back to the extremities. So this is helpful, but extra caution is required when the patient is in ICU with the multiple tubes connected to it. So this is how the variability is checked. And from there, this is a flowchart given by Daniel D. Becker in his publication, where patient is suspected of hypovolemia and you want to look at the fluid. You need to look at whether it is you are doing transthoracic or transesophageal, whether patient is mechanically ventilated or spontaneously breathing. For spontaneously breathing patient, do passive raising. For mechanically ventilated patient, if patient is in sinus rhythm, passive breathing, IVC distensibility, or respiratory variation of aortic flow can be used. Or if patient is having arrhythmia, in case of arrhythmia, still passive raising can be used and IVC distensibility can be used. In case of transesophageal echo, which we rarely use, this is the pattern we can use it. Now coming back to the last thing about the B line index. more the B lines, more the extravascular lung water. But many studies proven that amount of B line, the number of B lines or B line index has correlation with extravascular lung water. But the change in extravascular lung water and the change in B lines may not be correlated. So it is like you have to be good, you have to be examine it serially to have a judgment about B line index. B line index is little laborious to calculate. You have to measure in all the zones, total the number of B lines. But roughly what we do practically is put the selected 1 or 2 points, and in the same position, keep on looking serially whether number of B lines are increasing and whether B1, B7, B3 lines are increasing or decreasing as the fluid management is done. So, and last couple of slides, after which we'll discuss the cases. What are the benefits of ultrasound as a tool for management in shock? Bedside, real time. You can repeat without worry of side effect or the cost. You need to assess, act. Act means treat, and then see the response of treatment, and then again assess, and then again treat. So that means this, just like an audit cycle, you assess, do treatment, see the effect of treatment, then again assess, and then do vice versa. That means in the coming few examples that we are going to discuss today, we can exemplify that how you need to treat multiple component of same shock. That means patient may have cardiogenic shock with hypovolemia. Start loading fluid and see whether your IVC variability is gone away, your alveolar VTI variability is gone away, and now you are coming back to from cardiogenic and septic and hypovolemic shock. Only hypovolemia is treated. Now pay attention to cardiogenic. That's what I mean. That means you might have to diagnose that there can be multiple component to this shock, delineate the pathophysiology, treat one component at a time, see what happens in response to treatment, and then again come back to square one. That means this is not a one-time assessment. This is a serial assessment tool, and that's the advantage of ultrasound examination. So every time you do, don't forget to put the stethoscope. I would say that I would be fool if I don't look at ECG, don't look at the stethoscope, don't examine the patient, and only keep on putting ultrasound. And that is the fool's disguise. People have come to erroneous conclusions by flaunting the fundamental rules of medicine that don't go to point number 2, take history, do examination, put differential, then ultrasound. Every time you put the ultrasound, put the stethoscope, and then put ultrasound. And that means you can't detect wheezing from ultrasound. You can't detect evolving cardiogenic asthma from ultrasound. So that means this is an add-on tool, not a replacement of your basic clinical skills that you have acquired till now. You can examine multiple systems. Don't jump onto the conclusion by looking at one point. It facilitates bedside procedures as we have discussed. So these are the advantages, but it also has disadvantages that you need to have a dedicated ultrasound machine stationed in ICU. Man behind machine is very important and have a learning curve. And that's the reason why ISCCM and College of Critical Care Medicine has started a dedicated focused critical care ultrasound or the fellowship in critical care ultrasound to teach those aspects. And it involves not only theory lectures, but also mentored online discussions where students present their images, and all the faculty across the country, they fine tune their clinical skills or the ultrasound skills, and we discuss, and then actually they appear in theory and practical exam, and that's how at the end of a year they pass through the fellowship in critical care ultrasound. This operator's knowledge have his own limitations. So that means you, as you keep on doing, you keep on getting better, but don't jump onto the conclusion in first 1 or 2 year of knowledge and flout the fundamental standards of medicine. Professional lies by people on learning curve. Be careful. Those people who try to confabulate and try to fit into that, this is what I have measured, this is what I have seen. I have seen a clot going through right ventricle. I have seen a bubble going through pulse. pulmonary artery. I have seen a bubble. I have seen regional wall motion abnormality. It was present when I did my ultrasound. If you have not recorded, you cannot show it to your colleague. You cannot substantiate your claims. So don't forget to record. Don't forget to open a patient's study, name it, and then do methodological. Otherwise, many people have started, I would use the word abusing the availability of ultrasound, but put it, conclude, don't document, don't store the images, and move on. And then you keep on jumping the ultrasound between patients without cleaning the probe and make it a perfect tool for spreading multi-resistant bug from bed to bed. So be careful of, don't misuse or abuse the availability of ultrasound, because this patient with septic shock could have been having a very multi-resistant bug, and don't you make the ultrasound as a taxi for transfer between the patients. Multiplication of errors of measurement, just like Swan-Ganz catheter, that it is not the faulty catheter, it is the faulty interpretation of the data generated from the Swan-Ganz catheter has given is in bad name. And so can be the ultrasound generated measurements. So acquire proper images, then interpret, then measure, then conclude. If you are not sure of anything at any place, don't conclude. Raise your suspicion, request one of your senior colleague to again acquire the images and then interpret. Just you give an example, in the previous images, we have shown that patient had pericardial effusion but was not in tamponade. So that means just by seeing pericardial effusion, don't jump onto the conclusion. Transfer of infections between the patient discussed, and breach in basic normal medical practice is also enumerated. So what information do I need? Is there hypovolemia or preload? Then I would go to, is the patient going to respond to fluid? Assessment fluid responsiveness. Is myocardial contractility and chamber size is okay? Can I look for any obvious pathologies in echocardiography? Is there an obstruction in an entity? Do I need to relieve it urgently? How prone this patient is for pulmonary edema? Look at the diastolic dysfunction. Look at the B lines. Is the extravascular fluid is already there or accumulating in peritoneum and pleura? How much fluid is present in lung now? Can it take more? Is there any lung pathology to add on this clinical crepitations? Anatomy and pathology screen for vascular accesses we need to do, and suitable sites for paracentesis if at all. This is all the places how I would approach. So with this, any questions before we go on to the case discussions? We can take some questions here.
So there is one.
Go with sir.
Yeah, I am constantly looking for questions. There is one question by Dr. Josh Jarin Josh. He is asking, please show how to do hepatic and portal. I think this is
I think beyond scope of this today's discussion.
Yeah, we discussed about the management of the identification and management of the shock rather than how to do it. So probably in some other session we can cover that.
So if there is no question, we can just take up couple of cases to exemplify how we need to actually do it in real life. I would read out the case for all, then project the images, and then we'll open the floor for discussion. What is the interpretation by individuals? 18-year boy, road traffic accident, injury to face, chest, and abdomen. Admitted to intensive care unit after intubation. His temperature 96.7, heart rate 145, blood pressure only 60 systolic, respiratory rate of 45, and he is hypoxic, 67 saturation. On examination, he is obtunded, restless, looks pale with cold peripheries, tachypnic, and air entry is reduced on right side. His heart sounds are dual. Abdomen is mildly distended and tender. He is obtunded but moving all four limbs. His lab shows hemoglobin 9, total count 22,000, platelet count 1.9 lakhs, electrolytes are normal, creatinine is 0.6, and ABG shows pH 7.05, PCO2 of 65, bicarbonate of 15, PaO2 is only 45, and lactate is increased to 8.8. Chest X-ray is done but awaited. So I again summarize: 18-year boy, road traffic accident, looks like to be hypotensive, shock, very high lactate, PCO2 is high, bicarb is low, having mixed acidosis, hypoxic and hypotensive. With the positive clinical finding is all the features of hypoperfusion, right side air entry absent, distended tender abdomen. With this, we'll start putting the, this is what the clinical examination has found. So anybody would like to just open up your mic and start putting differentials, that what do you think this patient has? Then we put the ultrasound probe and then point forward. Anybody? We have 124 participants, as I can see. Anybody can do raise hands
No,
and
I can see that there are few answers in the chat box. Let me just enumerate them. There is one answer: hypovolemic shock with pneumothorax, obstructive shock. Another answer is pneumothorax tension. Third answer is hypovolemic and obstructive shock. Fourth answer is obstructive shock. Another answer is shock plus pneumothorax. Another answer is hypovolemic and obstructive shock. Hypovolemic shock, trauma, hypokalemic shock, hypovolemic shock with pneumo. So these are the answers.
Fine. So we, at least everybody has put one thing in common, that there is hypovolemia. Everybody suspected because of right-sided reduced air entry, they're wrong on the right side. Maybe pneumothorax, maybe bleeding there, reduced air entry, and tense abdomen.
Yeah, so, blunt abdomen with hemoperitoneum and abdominal organ injury, there are few other options.
Right. So here, either you can use this type of matrix where you start putting down your what you find, or this is the way. Here you can start putting this way, whether patient has point in favor, point in against, or another way is you can actually put a HIMAP chart. I have started for you. So when you start with the pump, would anybody like to comment what is there? This is patient. You know the history. You have examined this patient, and this is the heart. Is my video working or it's getting?
The thing is that the pump video is not working properly. Rest of the others are working, but right now nothing is working. So all the video have stopped.
Okay, I'll go back and then again start.
Yeah, so few answers are there, like
right. So
yeah, now it is clear. Hypovolemic shock with pneumothorax, and some Dr. Hari is saying that heart is empty.
Okay, heart is okay. From anybody would like to comment on IVC? It's small and
empty
collapsing.
LV. Another answer is empty LV.
Okay, and here on the pleura, what do you find?
IVC is collapsing.
Yes, IVC is collapsing. What do you find in pleura? What is this? You can see actually a lung point.
Yeah, some Dr. Binod has identified the lung point.
Right. So this patient has hyperdynamic LV, empty IVC, pneumothorax because there is absent air entry on right side. You have high index of suspicion. You found, and then you go on to next test. You don't jump on to conclusion. The important thing is, by looking at the heart, don't conclude that this is only hypovolemic shock. By looking at the IVC, don't. By looking at the pleura, don't. Again, I would see at the femoral vein, no DVT. And you did fast scan. This Morris pouch is empty. Right? So here you can go create a HiMap chart. Anybody like to put your words here? Heart, what did you find? It's an empty rapid hyperdynamic LV, correct?
Yeah, and
IVC, empty. Mauritius pouch, empty. Aorta, deep vein, no DVT. And pulmonary, there is pneumothorax.
yeah, barcode
Correct.
sign.
So,
Few of them has said barcode sign.
correct. So, now let's manage this patient forward. You have ordered X-ray, and this is what the X-ray showed. So this patient, very obviously, anybody would like to comment? Right? This is tension pneumothorax on the right side with a deep sulcus sign, mediastinum shifted to left, where right-sided ICD is placed and SpO2 is improved to 94%. Obviously, fluid resuscitation is started. After 2 liters of fluid bolus, blood pressure from 60 systolic improved to 90 systolic and heart rate from 145 reduced to 110. Now, you continue doing 45 minutes in the case. You did E-fast at 4 point. Now, fluid appears in the Morrison's pouch. You know this patient had polytrauma, tender, distended abdomen, initial fast scan, there was no fluid in Morrison's pouch. Now you have resuscitated this patient. You have drained the pneumothorax. Now you are on to another cause. This patient is still tachycardic, still hypotensive. So it is obvious that this patient has started bleeding in or oozing in the abdomen. So this patient had CT abdomen done, CT chest done, right-sided ICD was confirmed. Lung contusion was present on right side. That's also a reason for persistent hypoxia despite ICD. Liver laceration with blood in the liver capsule was found. Hemoperitoneum was found. And this patient had laparotomy. Liver was repaired. Packing was done and closed. And thereafter, he got stabilized. So meaning thereby he had hypovolemia. He might have bled externally because of injury on face. He had internal. He had pneumothorax. That's what causing obstructive shock. Even with obstructive shock, IVC was collapsing because patient is practically exsanguinated. So after draining ICD, after giving fluid, patient has started the internal hemorrhage became more apparent. So this is how repeated examination by ultrasound helps you to find out multiple components of one shock. Let's take so here you say these are the tricks which I have done. This is the area you have you benefited by point of care ultrasound. So let's look at second case, and that's the last case. Thereafter, we'll open the box for discussion. 76-year male, known case of ischemic cardiomyopathy with ejection fraction of 20 to 30%. For chronic kidney disease stage 2 with CABG done 4 years ago in the past history. Admitted to intensive care unit after fever and loose stools, and he is continued to have fever 100.3, heart rate 128, BP 80/60, respiratory rate of 34, saturation of 92. So this patient, elderly gentleman, male, ischemic cardiomyopathy, now down with fever and loose stool. So is obtunded and restless, looks dehydrated, tachypnic, air entry reduced at both the bases, occasional craps are there, S3 gallop is noted, extremities are cold and clammy, abdomen is soft and non-tender, CNS is obtunded and no focal neurological deficit found. He has normal hemoglobin, total count of 14,000, platelet count little low, which is 90,000. His electrolytes are okay. Creatinine baseline was 2.5, now it has increased to 3.6. ABG suggests of acidosis 7.26, PCO2 of 25, bicarb of 15, and PO2 is marginally low, which is 55. So he has metabolic acidosis, and lactate is 5.8, NT-proBNP is 1500, cardiomegaly on X-ray with dilated blunted chest. Now again, either you can do this matrix analysis, which I have already written, and we will start playing the video one by one. So this is the left ventricle, or this is LV, this is RV, this is how his heart looks. So this patient is already case of dilated cardiomyopathy, now presented with fever and loose stools. This is what his IVC look like. Okay, this is his deep vein look like. And this is his abdominal ultrasound where the IVC is and aorta is normal. So anybody would like to put differentials? This patient has dilated cardiomyopathy, poor ejection fraction, but collapsing IVC. And tachycardic and no DVT. So this patient is septic plus hypovolemic plus cardiogenic shock.
Yeah. So one answer is septic shock with DCMP.
Right. So this is sepsis leading to decompensated heart failure. You should always suspect when patient is having background heart disease, any new event is very likely to decompensate heart disease. So this is septic plus hypovolemic. Why septic? Patient is febrile. Why hypovolemic? Patient is already IVC totally collapsing despite very poor LV. And why cardiogenic? Because it's global hypokinesia. And this patient is in shock. So all the three components are present. So how would you start handling? Again, you can create this HiMAP score. I don't want to discuss. Again, is that four chamber dilated, IVC collapsing, Morrison's pouch, no fluid, aorta, DVT, okay, and pulmonary trunk. You can see that whether B lines are present or not, which data is missing here. Here, now, this is the patient where I would like to monitor under the serial LVOT guidance, LVOT VTI. Heart rate 128, saturation 92, and LVOT VTI is very low. 20 plus or minus 2 is normal. So 13 is extremely low. And the B line index is less than 3. So there is hardly any B lines even if this patient's LV is poor. That means he is hypovolemic and dry, as it appears clinically as well. So you are given 300 ml of normal saline and again repeated, which reduced the heart rate from 128 to 118, and saturation marginally dropped down from 92% to 90%, and LVOT VTI marginally improved. Still, there are no B lines. You again dare to give another 200 ml of volume, which further reduced the heart rate to 108, and saturation hangover almost same as 89%, which but improved LVOT VTI. Again, you look at the B line, they are again same. So because still there is poor perfusion, persistent tachycardia, patient is oliguric, obtunded, you give another 200 ml of fluid, and now heart rate has settled down to 100, but patient started getting desaturated, that is 86%. LVOT VTI has not improved. That means after this almost 700 ml, now patient has gone from steep portion of Frank-Starling curve to flat portion, whereas LVOT VTI has stopped improving. And B-line index has started increasing. Hypoxia has started worsening. Where you thought that no, this is the limit, we cannot tolerate any more fluid. So you decide to add on dobutamine, add oxygen supplementation for treating hypoxia. Now, what dobutamine did, with it increased heart rate, oxygen supplementation improved saturation, but VOT VTI has improved to 17.2. 18 is your desired, so you are moving towards it. Then your B line remains almost the same. So you continue IV dobutamine, and you dare to give another, say, can I give another 100 small amount of fluid, because dobutamine would have shifted the Frank-Starling curve little bit because contractility would have increased, So this patient can tolerate, accommodate little bit more fluid. And after this, saturation is okay, LVOT VTI is okay, little bit more congestion. This point, you stopped IV fluid, and this patient's hypovolemia is covered. By this time, you have already given antibiotics, sepsis is covered, and heart cardiogenic shock is supported by dobutamine. So this is the way in real life but you have to cultivate the art of accurately measuring LVOT VTI. Say these are operator dependent tests. These are fine things to be detected. It requires a lot of experience, and what we do is you literally make a marker on the skin that this is where I am going to measure LVOT VTI. I'm getting best. So keep the patient into same position. Do not alter anything else. If patient is hypoxic, if you put the patient on NIV, that will also reduce the heart rate. And by reducing the heart rate, LVOT VTI also will change. So to interpret, you have to have a extreme word of caution. Very rarely you'll be able to get this type of, because patients are tachypnic, uncomfortable, they move around. So this is, I have given an just a theoretical viewpoint that this is where you can monitor it and manage the cases. So they have ticked the boxes where.
So there is one, I don't know whether it's a question is relevant here or not. If the patient is in shock, is it fine to start dobutamine instead of NORAD? I think we are talking about the ultrasound, not talking about the management issues. So I think we can skip this question. I just
Yes,
want
but
to
of
just
course, that depends on what's the blood pressure at that point. So you are perfectly right. Of course, this patient has, if it is hypotensive, you look at the S prime, you look at the LVOT VTI, you look at the, so you have to select the vasoactive agent or the, here I'm trying to exemplify that for LVOT VTI, you need dobutamine. If this patient hypotensive, obviously I would add noradrenaline to it. That's a clinical question. Certainly you need to consider that. I completely agree with it. But what I need to convey is try to identify multiple components of shock and handle it one by one as the priority takes it.
Yeah, so
That's the conclusion.
in the cardiogenic shock, if it is a initial stages, dobutamine can be given, so it is not the problem because we need to increase the cardiac output anyway. So rather than going discussion to the different direction, let's move to back to the ultrasound,
So,
please.
so this I'm going to next 4-5 slides. I'm just projecting one image. You can comment in the chat box. What do you feel? And then in couple of seconds, I will tell you the answer. What is this? Everybody will appreciate that. So everybody say this is pericardial effusion. Is there tamponade? Again, the ideal answer would be yes, there is pericardial effusion and tamponade in diastolic collapse. But is this end of the story? No, you will complete the protocol. You will look at the IVC, you will look at other causes. This patient might have pleural effusion. This patient might have pericardial fluid also. This patient might be bleeding everywhere. This patient may be presenting with dengue with polyserositis. So don't jump onto the conclusion just because you found the pericardial tamponade. That's the moral of the story. Again, put your comment. What is this? So it is obvious. Anybody answered? I can see the chat box.
Sorry, yeah, my microphone was off. So pulmonary embolism, P majority is saying P. One person is saying cardiogenic shock, one is saying RARV dilated, pulmonary embolism.
I don't think this is the way where you have seen RARV dilated. I don't see anywhere. This is very obvious that this is a very poorly beating LV.
Yeah.
You look at the distal interventricular septum is thin, apex is not contracting well. There is a decent, might say one thing is very clear. In a patient with RARV dilatation, if your LV is not empty, that's not a cause of shock. As simple as that. Your RVRA have be so big and dominant problem that LV is empty, then only blood pressure would drop. And then only patient will have shock state. So obviously this RARV is not dilated. There is tricuspid regurgitation. You can see very poorly coapting mitral valve. There is a central MR jet. The distal interventricular septum is thinned out and hypokinetic. Apex is practically akinetic. So this is a case with a myocardial infarction, very likely with a, obviously without clinical details, it is difficult to put differentials there. But this is what is apparent from the image. Again, will I conclude? The answer is no. I need to again look at the B line index again, but very likely there is a cardiogenic element to it. Don't jump onto the conclusion. Now, this would be very interesting. Patient with chest pain, pulmonary edema, brought to ICU, intubated, and is a very severe shock. Blood pressure is around 90 systolic, heart rate around 130, pink frothy, and cold peripheries. What do you think is the cause? Sorry, it's not very good quality image. It could have been much better, but because it's one of the rare things we find, this is a apical 4-chamber view. The gain setting could be better, but anybody would like to put your comments? Septal defect, VSD, cardiogenic shock. Anybody else?
Severe MR rupture.
Severe MR, rupture of what?
Septal
rupture. Okay. So this point is well taken. I completely agree with on this, that this patient has, it's a tachycardia, distal IVS interventricular septum is thin. You can see a jet going from here into, can you pursue this jet? Can you see my arrow?
Yeah.
Yeah. So this is a ventricular septal perforation because of anteroseptal MI. That's why, and you can see a very thinned out distal IVS. And from there is a rent, and that's where you can see a jet going from left ventricle to right ventricle. So it is correct to diagnose, and this is the patient. You will have a literally pansystolic murmur on chest. So those who would auscultate, and I would not be wrong in telling that even our echocardiographer has missed this VSD, and the junior most medical officer who stick to basics by putting an a stethoscope on the chest, and they draw our attention. So this patient has a pansystolic murmur and he has a shock. So that means we carefully look for mechanical complication of myocardial infarction, and this is what we found. And this patient was immediately taken off for bypass surgery and ventricular septal repair, and has survived. So that means stethoscope dose lower the index of suspicion, and that's where, say, this is a modified. You can see this is not an ideal apical 4-chamber view. We have to tilt the probe to look for it because IVS was very thin. RV looks little full. in a patient with left ventricular infarction, or why the RV would be so full, why there should be pansystolic murmur without severe MR. So that's where this is the cause. So this is rare, but again, I would not jump into the conclusion. Go back to complete the protocol and then don't conclude. So I would remove these annotations.
I think we should conclude now. Time is over.
The last two slides.
Yeah, please.
Just complete it. So again, it is obvious. Can anybody comment what you see in the left ventricular cavity? That is called spontaneous echo contrast, SEC. This is a marker of very slow flow. So this patient has global hypokinesia and then slow flow. Spontaneous echo contrast in a patient with cardiogenic shock. So last two slides where this ultrasound is not only going to help in differential diagnosis, assessing fluid responsiveness, help in procedures for managing shock, but help in multiple aspects of monitoring hemodynamics, which we have seen one by one in different cases. But I would end with this, my last slide, which I remind myself that every time you try to become more educated, more skillful, I would remind myself not to flout the fundamental rules of clinical practice, is never break the paradigm, history, clinical examination, then only critical care ultrasound. Complete the protocol of critical care ultrasound for the clinical discussion. Never jump onto the conclusions. Remember, there can be multiple causes to the same sign and symptoms, multiple etiologies. Rule number 3, save the named clip for the review by others. Otherwise, there are evanescent signs. The right ventricle, the regional wall motion abnormality may settle down once you correct the hemoglobin, put the patient on ventilator and do corrections. The once ST is settled, RWMA may go. So I would call it railway station effect. If you are there on the platform, you will see the train. If you are late or early, you will not see the train. So please save the named clips. That means store on the patient's name. Otherwise, you will never be able to reproduce even in court of law that I have seen pulmonary embolus passing through right ventricle. Because once you store it, it will be stored in other patient's name. And even if you produce in court, the image would bear other patient's name. So that would not be valid. Serial critical care ultrasound is the norm, which I don't need to overemphasize it. Have timely review. Don't have a thought tunnel effect. As it given in the patient has pericardial effusion, there's a little bit collapse of RV. So this patient is in tamponade. This patient is completely collapsing IVC, can't be in tamponade. So look for other cause of shock. That's what it means. So with this, I'll end the session. I hope we had uh, if permits, we take questions and some discussions. Otherwise, I think we already overshoot the time. Thank you very much for this opportunity to interact.
So we can take one or two questions if there is any question. Most of the people are just thanking you, Dr. Anuj.
Any questions in last